this. So yeah, this is Shinmi, a distinctive Japanese medical virtue by Reina Ozeki-Hayashi and Dominic J.C. Wilkinson in the Asian Bioethics Review. As a perspective. Interesting. So let's go find out. I want to know what a uniquely Japanese virtue is. Here we go. Like I said, feel free to stop me along the way and we'll see what this has to say. Much has been written about the ideal doctor-patient relationship and the doctor's attitudes in terms of professionalism and ethics, mainly from the West. Although there has been less analysis of the concept of a good doctor in other cultures, different contexts, social values, and healthcare systems might give rise to different norms. The preferences of both doctors and patients will also potentially vary depending on cultural background. In many countries' medical education systems, concepts from Western countries are imported and translated. However, it is possible that distinctive national professional norms might arise that complement or compete with those Western ideals. And I think this is a good point. Like, I once said, like, I've got Jewish, like, background. Someone once came up to me and was like, I really like my Jewish doctors. They have a really good bedside manner. And they're, like, telling me this like it was a compliment to me. Like, I'm not a doctor, but I'm, like, happy that you had a good experience with them. Have a good night, Lumpy. I'll give Lumpy a shout out. Lumpy is one of our buddies. Shout out Lumpy Dragon Potato. Lumpy Dragon Potato is Canadian, and I think he speaks French. But I've been watching some Canadian streamers, but yeah. So he streams Minecraft, but like during his Minecraft streams, it's like just chatting. So he talks about life philosophy, money, finance, business, science, and all sorts of good things. You're gonna get back on streaming next week. Yeah, he's had some stressful weeks at work. Lumpy is a chemist. He makes chemical things and reports his results to rich people who are trying to make drugs and other whatnots. But yeah, so it's cool. So, thank you for being here, Lumpy, and drop Lumpy a follow if you don't mind. So, okay. But, like, yeah, so there's, like, what is bedside manner? Like, as a concept. And I know Twitch skews a little bit younger, but I know the people in this community also are probably a little older than the Twitch demographic. So, it's like, you have doctors. Some of your doctors I bet you've had suck. And you're going to have some good doctors, some bad doctors. Not that they were bad doctors. You just don't want to deal with certain people. So it's like, this is a thing. This is a very real thing. And when you're young, you don't have to know about this. When you get older, you do have to know about this. And so this is like actually like, important for everyone eventually to realize that we've been seeing your doctors less and less, and you're doing more and more of this, like filling out like paperwork and stuff, and you're just like checking off boxes and it's going to send through the AI. But that does not actually mean for better health outcomes. And so there is something to be learned here. Okay. In Japan, one term used by professionals and the public to describe the ideal form of medical care is Shinmi. And Fernald says, my GPU told me once to give myself to God when I went to get antidepressants. Lol. Yeah, and see, that's the problem. That's a shitty doctor. Be like, oh yeah, like religion will solve your problem. No, it won't. No, it won't. One of my doctors once called me a vampire. Well, he said, you look like a vampire. I was like, okay, thank you, doc. The dictionary definition of this word includes several distinct meanings. First, it refers to a person related by blood or a blood relationship. It also refers to taking somebody to one's heart, for example, to look after somebody with tender care. The related adjective shinmi na means amiable, cordial, kind, good-hearted, and benevolent, open-hearted, etc. Kindness or benevolence appear similar to the desirable attitudes of healthcare providers in Western countries. Because you're too pale, because you look good in a corset. At the time, I was rather sick, and it was the pale at back then. I don't know how I look in a corset, though. That might be something else I have to try out, and maybe I'll get a third vampire one. And the other time was one of my buddies said he thought I was a vampire. But then again, he may have been on lots of drugs at that point. So, yeah. So, so there are better and worse ways doctors can go about telling you how you are feeling and how you look to them than being told I'm a vampire or that religion will somehow fix your problems that have nothing to do with religion. Or maybe religion is the problem. Yeah. Okay. However, as other definitions such as tender care like family suggest, Shinmi is not merely kindness but also implies a level of care for patients as if they were doctor's own family members. It suggests a psychological proximity and a potential blurring of professional boundaries. Well, there's a job for Cinematics, plus a Nogreo in a corset. Oh, there we go. Now we're getting somewhere. See what AI thinks about me in a corset. It's like, do I look good? I better look good, damn it. Okay, in this paper, we will introduce the concept of Shinmi in Japanese healthcare through a fictionalized case that includes a doctor's Shinmi na attitude. We will define the key elements of Shinmi in healthcare and identify some potential problems. Finally, we will analyze Shinmi through a virtue ethics lens and make suggestions for how to avoid excessive Shinmi and maintain a balance between the needs of the patient, other patients, and the doctor in medical practice. Yeah, I was just thinking, my grandma was in ICU at one point. She was in intensive care, and the nurses in intensive care were like steps above other nurses. Like, I'm not surprised maybe they had a lot more leeway and time and support, but they were like, we had this one guy, he was just fantastic. He was just like the most caring, awesome nurse like I've ever dealt with. Now, I'm not saying the other nurses I've dealt with were bad. It's just I think he just had the time and ability to be as good a nurse as he could for the ICU people, and like you can tell it makes a difference as opposed to people who are, understaffed and just trying to get their job done versus someone who has like the proper support. So yeah. Okay, so I guess what's going to happen in this paper is they're going to describe it as they said and then discuss it. So this is like a big thought experiment here. So we haven't had a big old thought experiment paper in a while. I actually like them. Some of my papers are kind of like this. I give you an idea and say, hey, look. And there's two different ways. Like you've heard, this is one of the things I like to talk about. How do you write your philosophy papers? What are you doing? There's different ways. Some people build fancy things. Like they're good at Legos. They make castles out of their little pieces. Me, I'm like, hey, look at this thing. I'm not like an argument I am an argument person, but what I do is I say, hey, look at this interesting thing, and here's what follows. So my arguments in some sense are much simpler. I say, look at the thing, therefore that. Other people, they say, hey, look at this, look at this, look at this, and if you put it all together, then you have this fancy thing. So this is kind of the, hey, look at this, here's what we're going to conclude style of writing. And this is closer to what I quite often do. All right. When Dr. B was a young doctor, she was responsible for a female patient Y in her 50s with gastric cancer and peritoneal metastases. I have no idea what this is. The patient had been admitted to a hospice as further curative treatment was deemed to be futile. Y had a husband and a daughter at university. She was B's first patient on hospice duty, and B was nervous but hopeful that she could manage Y's distress. During Y's stay in the hospice, her pain gradually worsened. She was slowly dying. Y wanted to spend time with her family, but her daughter and husband could not accept that she was dying and rarely came to see her. Dr. B had a good relationship with Y. She always described Dr. B as Shinmi na doctor. During her residency, her supervisor had taught her to treat patients as if they were her own family. Unreal says, intestinal cancer spread to the lining of the sac enclosing the abdominal organs. That sounds terrible. Like, you're going to die. And so I guess that's what happened here. So, yeah, icky. Dr. B was, cancer sucks, by the way. Dr. B was pleased that Y trusted her and that she had established what she saw as the ideal relationship with her patient. Dr. B spent more time at Y's bedside than with any other patient, and they began to talk a lot about other things other than work. As Y's family distanced themselves, B found herself becoming angry and resentful towards them and felt that she had to support Y instead of Y's family, who seemed cold-hearted. When Y had to make a difficult decision, she asked B, if it was your mother's case, what option would you choose? When nurses could not find Dr. B on the ward, they would sometimes go to Y's room imagining that Dr. B would be there. Y was fully aware of her medical condition and had already indicated her intention not to receive cardiopulmonary resuscitation. Dr. B wondered if it might be better to prolong Y's life with CPR even against her wishes, to give Y a chance to spend as much time with her family as possible. Dr. B resisted this temptation. Ultimately, Y died without her family having enough time to spend with her. After Y's death, Dr. B felt a terrible loss and was mildly burnt out. Dr. B left the palliative care unit 2 years later. All right, 2 years though. In caring for Y, Dr. B provided family-like, dedicated, and special care for Y, which she did not provide to the other patients. Dr. B reacted strongly to and shared her patients' emotions and developed strong negative feelings toward Y's family. In retrospect, Dr. B acknowledged that at the time, she did not realize the importance of psychological distance from her patient and did not achieve a proper balance between emotional involvement and clinical detachment. She lost her professional objectivity before the patient's death, and this contributed to her becoming burnt out. Dr. B had tried to be the Shinmi na doctor, the ideal in Japan, but why did it end up this way? We will start by considering what constitutes a Shinmi na doctor. Okay, so, there's a few things here. Clearly, she got over-involved, but on the other hand, why? The old lady, really, I'm sure, appreciated the extra care. The Shinmi na medicine doctor. In Japan, medical professionals with a Shinmi na attitude are considered virtuous practitioners. In addition, many Japanese patients understand Shinmi na medical care as ideal. For example, a search of hospital and clinic websites identified a number of institutions who explicitly describe themselves using this adjective. That is interesting. So this is becoming professional. A separate search of patient comments and complaints left online yielded a number of characteristics of either Shinmi and non-Shinmi doctors. Yeah, so imagine like rateyourdoctor.com and it's like Shinmi or non-Shinmi. It's like, yeah, the old rate your professor. How hot or not are you? How Shinmi are you? These results support the idea that Japanese patients perceive a doctor's Shinmi na attitude as the doctor's familial and emotional involvement as if they were patient family. The term is used to describe hospital policy or values and is also used by patients as a mark of good doctors. The Japanese doctor's version of hot or not? Yes, exactly. Shinmi na or non-Shinmi na? Exactly. There is ratebydoctor.com and whatever. If you look up doctors... Doctor ratings. You're going to find best doctors in New York near me. See, look at this. ZocDoc, best doctors in this area, in the New York area. So this is the thing. You're going to get 4.92, 4.97, 4.79. And these are really nice headshots they got. These are professionally done headshots here. 4.77, nice headshot, mister. These are professional. So it's it kind of is not any different than hot or not. You're getting these real nice headshots, little ratings and stuff. It's a thing. So, and you might not have this where you are, but we get publications, best doctors in New York, and you'll go to doctors' offices and they'll have that there and they'll have themselves circled in the little magazine that says best doctors in New York. I've gone to a doctor and he would do that so you could see he was there. Yeah, rate my prof, exactly. Well, I don't know if you remembered, Rate Your Prof used to have hot or not on it. They took that off because, it started off as more of a fun thing and then it started getting used and it was inappropriate to have a hot or not. My old friend from grad school, she was working and she said, I don't really care how low my grade gets as long as I still get they had a chili pepper. So as long as I keep my chili pepper, as long as I think I'm hot, it's okay. So that was Rate My Prof, yeah. Okay, so, however, as the case example illustrates, if a doctor tries to be an overly Shinmi na doctor, it can be detrimental to both themselves and to their patients. In the next section, we will describe two separate elements of a Shinmi na doctor and identify the problems that can arise if this is pursued excessively. Yeah, so instead of being a virtue, it can turn into a vice. So this is still in you can describe this in Western terms, but it's interesting. So, okay. So these are a Google search for medicine and hospital. And so these are claims from people's websites. Shinmi na medical service, medical care. Shinmi na care like a family. Shinmi na care for everyone. Medical service for every patient and patient's physical and psychological concerns like a family. So it's interesting. They have this familial sort of bent to it. We don't do that here in the US, or I've never seen that. But this is a question: what actually gets you a better medical outcome? And anyone who's dealt with the theory here, I don't know, of course, the practice, but there is so much that is it's not actually the medicine. It's how people feel about stuff really makes a big difference in how they get better. So it's it's a thing. It's not. It goes well beyond like the placebo effect. Okay, Shinmi not attitude. 1. Familialism, or do they mean familialism? I don't know. I don't know the word. Okay, one clear element of the meaning of Shinmi is that the doctor treats the patient as if they were a member of the doctor's family. We could refer to this as familialism, a term that indicates a cultural value placed on close familial family relationships and prioritization of family members. In Japan, this may reflect the influence of Confucian and Neo-Confucian values, which arrived from China in the Suka period, 5th and 6th centuries, but were embraced and disseminated especially in the 17th and 18th centuries. Oh, I did not know that it was that old. I mean, that recent. That this is when it like actually took hold. Interesting. In Confucian society, the community of significance is the family and its extension, the kinship community. In other words, the stronger the blood-related ties, the stronger the degree of care. Yeah, I mean, let's see. Yeah, I don't know. I'm trying to think of a similar thing in the West where we'd say something like this, like family. It's not. We don't say family style care. I mean, I don't want my family doing medical stuff. Like no. Okay, one form of familialism is when health professionals treat their own family members. The permissibility of this varies from country to country. There are no guidelines or laws against doctors treating family members in Germany, Malaysia, Japan, and other Asian countries. In Japan, Matsunaga et al. Report that about 80% of family physicians had treated their own family members, and almost 90% were satisfied with their behaviors. Interesting. On the other hand, in many Western countries, guidelines prohibit or strongly recommend against doctors treating their own family members. Reasons for this prohibition include the risk of 1. Losing objectivity and blurring the professional boundaries between patient and doctors. 2. Compromised continuity of care. 3. Doctors making errors in medical judgment. 4. Necessary information not being communicated due to preconceptions of the patient or reluctance to deal with sensitive content. 5. Over-medication or under-medication. And 6. Problems with confidentiality. It's like, yeah, if I had to go to my parents and like ask them like the medical stuff, I don't think I'd want to talk to them. Valpo says, so girlfriend experience providers in the West, family surrogates. See, in some sense, like that's kind of jokey girlfriend experience, but you do want to feel like there's someone you can talk to, like you're open to that, and like maybe there's something to that because in the West, I've had very, you sometimes you have very business-like people you're dealing with, and you can't really discuss things with them. They don't want to hear it. Actually, my current primary care doctor, he's kind of intense. Like he'll be like staring at you, like he'll be like laser focused at me, asking me questions. I'm like, oh, good. Like, am I lying or something? I feel bad. Like, but I tell him like I have no reason to lie to the dude. But it's like he's not like a lovey, family-friendly guy. He's like sort of an intense dude. He's a very good doctor, but he's like an intense dude. So it's like, yeah. So it's like maybe there is a better way to get information out of people than being intense. Like really. And so it might work for him sometimes. I don't know if it works for him all the time, but like that's the thing. So, but he is a good doctor. So I kind of like him. He's kind of conservative too. He's like, I tell him stuff. He's like, hey, you're fine. I'm like, yeah. And like other times he's like, no, let's like look into that. But like sometimes I told him something. He's like, nah, that don't matter. I was like, hey, that's what I wanted to hear. It's like, I don't want to have to deal with any of this crap. So yeah, he yells at me. I have to go see other doctors. I haven't done that, but things to do. I'm gonna go see some other doctors too. Getting old, So yeah, girlfriend experience. But like again, maybe there's something to that. Okay, one instantiation of, I hate this word, familism, is that it may be familiar to Western doctors is when a patient asks a doctor, if the patient were your family member, which treatment would you choose? This question can be gratifying for doctors because it shows that patients trust their doctors. For patients and their families, asking this question to the doctor is also meant as a request to certify the doctor as the authority in the family member's care, to have the doctor take part in the moral burden of making difficult decisions, and to be more involved in the patient's care. However, Truog states that a doctor meeting such demands is risky. Quote, physicians are experts in medicine, but not in patients' values. Doctors should address this question carefully as it relates to the more general and controversial area of defining the boundary between doctor and patient. Truog warns about the potential for doctors to lose their objectivity. Again, is that really the worst thing in the world? Maybe you need a little bit of subjectivity to understand the patient's state, and then, custom tailor care to that thing. Yeah, that's the other thing, Unreal. Brian, please don't sue me. Yeah, you have to be very risk averse, and that pushes everyone onto the, the numbers, whatever the numbers say, like doing the book standard thing. But that's, again, not always going to be the best of care. And that's the question here. What else can be done in terms of care? This is a virtue in some sense. Now, is a virtue a thing? Well, no, but you can still, we still have bedside manner. That's the question here. What is the proper way to deal with patients? Because this is a thing. When people are feeling sick and hurt, you need to have their trust. You need to talk to them. And I know we've rehearsed this a million times on this stream and others, but God forbid you're a black woman and you're going and talking to a doctor. It's historically bad how little they're listened to. Black women, their pain is not taken seriously when they go into a medical facility. And, medical outcomes are much worse because people are not believed due to, epistemic injustice and all this. So yeah, that level of care is not scalable. Well, sure, but again, that's also, that's capitalism. I mean, we should be having better care, regardless. And there are things that have been done to, it's not scaling personal attention, but a lot of things, for instance, my parents both worked in healthcare, so I hear about this stuff, or I did. And the noise in the hospital, if the hospital is noisy and you people can't sleep, their medical outcomes are worse. And so it's there's wait times should be cut down. No, excess noise can be cut down. So all of that stuff actually goes into what patients feel has been good care. So certain things are noise levels, that is scalable. You should be having quieter hospitals. You can do that. And so it's little things do add up. So yeah, it's can you have a patient like your family? Maybe not, but also maybe you can. I don't know. It's yeah. Okay. Further criticisms of familism include an inherent tension and potential contradiction in the concept of treating patients in a way that is similar to treatment of family members. Within familism and within a Confucian norm of family relationships is the idea of special treatment of family members, giving them attention and care over and above the care provided to others. Yeah, this is the problem with the example above. She way overdid the special treatment of that one patient. In this approach, familism takes precedence over the interests of society as a whole, leading to a lack of attention to the public good. And this is what Semiotics was bringing up too. If you basically overdo it for a few people. However, this might contradict other ethical duties. For example, the need to distribute limited healthcare resources equitably, as well as to achieve the greatest good. Excessive Shinmi raises problems from the perspective of equity. Furthermore, this approach to providing special Shinmi patient care may ultimately be self-defeating. Treating every patient in the way that family members are treated would mean that family members and non-family patients no longer receive special care. Yeah, I guess, but you want the highest level of care, and you want to feel that you're getting the highest level of care. It's yeah, is this family member level? Well, if your family member is getting the similar stuff, that's as good as. It doesn't necessarily need to be special. It just needs to be, as good as as well taken care of as you want to feel. Okay. Unreal Brian, does talk of equity bring utilitarianism to a virtue fight? Well, that's exactly it. That's exactly what happened right here, Unreal. This is part of the problems with, utilitarianism and consequentialism. This is well, look, you're trying to be healthcare for society, not for like individual people. This is not like only one or two people get the best care because we love them. It's like this is for society. And so like the virtues, this is one of these things like, well, virtues don't all like can turn into vices if you overdo them. And it's like this is why you have to get called out by the utilitarians. But like that's the point, is that like this is not a universal virtue. It has to be in moderation. I'm sure Aristotle would have said, but again, like, what does it actually amount to in practice? Okay. Emotional closeness. Another element of the meaning of Shinmi is the doctor's more emotional involvement with the patients. If Shinmi na doctors see their patients as family members, this can potentially trigger the same emotional reaction to the patient's situation that they feel towards their family members. For example, in ordinary circumstances, doctors would not necessarily be unduly affected by learning that their patient has been diagnosed with cancer. However, if they learn that their wife or parent has been similarly diagnosed, it is natural that they would be strongly affected psychologically. If the doctor has a Shinmi na relationship, the same response may be evoked. And I was just thinking, a lot of people here are educators. Do you treat your, students as like your kids? No, you need a distance there. But like, would it be good to be able to emotionally engage with them? Maybe sometimes. It's like this can also be, who is the patient here? Are they a student or are they a person who's sick? It's like, this can generalize. Okay. Emotional engagement with patients in clinical practice has been discussed in the context of trust and communication with the patient. Medical professionals are often expected to communicate calmly, keep their emotions at bay, and reduce their emotional reactions. In particular, there have been numerous studies on empathy, positioned as necessary in healthcare for building trust with patients and facilitating healthcare. Empathy is sometimes divided into affective empathy, the subjective experience or sharing of another person's feelings, and cognitive empathy, quote, the ability to identify and understand the feelings and perspective of others from an objective standpoint, end quote. Affective empathy is said to be more likely to be felt towards those in close personal relationships and those similar to you. Shinmi na doctors feel they have a psychologically closer relationship with their patient, akin to family members, and this may trigger affective empathy. However, Jody Halpern argues that affective empathy should be avoided in medicine. She contends that when doctors use affective empathy, their emotional reactions reduce the quality of cognitive understanding of patients, impede objectivity, weaken the ability to provide effective healthcare in difficult situations, and increase the risk of physician burnout. In particular, working with patients with affective empathy over a long period may prevent doctors from seeing the situation from the professional distance necessary to identify the best option for the patient, and they may try to provide all possible treatment. This characteristic of affective empathy also means that empathy is not provided according to the need of the patients. There are criticisms that effective empathy is partial and biased and is not offered fairly to all patients. This is the thing. It's like, yeah, but people like it. And so people want to feel like your doctor likes you and is giving you the best stuff possible. Like you like it. And so I was like, maybe this isn't the best care, but like something else needs to be there in order for you to feel like this. It's like, do you have to like get this? It's like you need the both. It's like, this is what the future of medicine is going to be. You're going to have the doctor in the room, like trying to be all emotional with you. And then you're going to have like the computer telling them like what the actual treatment should be. So it's like, you're going to have to balance this stuff out, but I expect this is coming. Okay. So these are some of the problems. As Unreal Brian pointed out, this is the utilitarian criticism up here, and then this one is the what could you call this criticism here? This is the criticism from emotionality, criticism from subjectivity. What is this? I don't know. But like, this is a criticism from subjectivity, where the more subjective you get, the less you're going to be following standard medical advice. So yeah. Okay. Yeah, so yeah, subjectivity or like perspective. I don't know. Interesting. Could come up with something. Okay, a virtue ethics approach to Shinmi. How should we assess Shinmi ethically. Shinmi is not an ethical principle, rule, or duty, rather appears to be a cluster of attitudes and behaviors. It is a potential characteristic of ethical doctors. Moreover, as already noted in the case and in the comments of patients, it may be over or underexpressed. In that sense, analyzing Shinmi through the lens of virtue ethics may be helpful. Yeah, because you can overdo everything. Virtue ethics is often distinguished in its emphasis on virtues or moral character in contrast to approaches that emphasize duties or rules, that's deontology, or consequences of actions, consequentialism. So these are Hursthouse and Pettigrove. Is this the SCP they quoted? Let's just go see. 2022, Hursthouse and Pettigrove. Yeah, Stanford Encyclopedia of Philosophy. Okay. Edmund Pellegrino has argued that the traditional professional medical norms were virtue-based, linking good physicians to specific character traits. Well, this is what I was saying. Bedside manner is a phrase. I don't know if everyone understands what I mean. Like, if you don't understand what I mean when I say bedside manner, but like that's a phrase that basically means how you interact with your doctor. And like if you have a good bedside manner, then you have a good working relationship with them. You can talk to them. If they have a bad bedside manner, then it's like you don't you do not enjoy interacting with them in some sense. Okay. Citing Aristotle's moral virtue, which on Aristotle's account were to be pursued neither excessively nor insufficiently, he defined an excellent virtuous physician as one who most effectively achieves the goals of medicine and exhibits traits essential to achieving those goals. Pellegrino's influential account included 6 specific virtues of doctors: fidelity to trust, honesty, compassion, effacement of self-interest, courage, and justice. No indication of familism, an element of Shinmi, is listed here, but emotional involvement is mentioned in the form of compassion, which refers to the need to enter the patient's predicament and feel their suffering, akin to cognitive empathy. While Pellegrino's virtues are grounded in Western culture, there are also physician virtues that have been described in Eastern culture. Some of these include similar elements to Shinmi. According to Daniel Tsai and colleagues, ancient Chinese medicine ethics were derived from Confucian virtue ethics. The central theme of this is Ren, with family values and filial piety, particularly being the root of benevolence. As evidence of the influence of this, it has been suggested that the book Bushido, written by Inazu Nitobi, which describes the way of the samurai and has its origins in Buddhism, Confucianism, and Shintoism, has influenced professionalism in Japanese medicine. Bushido is similar to chivalry or noblesse. I don't know what this word, noblesse oblige, in the West. In Bushido, 7 virtues are advocated: rectitude, courage, benevolence, politeness, honesty, honor, loyalty, and loyalty. Of these, Jin and Chugi, so that would be benevolence and loyalty, are similar concepts of Shinmi. Benevolence, which means love and compassion towards others, is an attitude of emotional involvement and empathy towards others. According to a survey of Japanese physicians, many stated that Jin is an integral part of medicine. Furthermore, Chugi, loyalty, prioritizes loyalty to the needs and interests of the group, such as family, in contrast to Western individualism. Unreal says, noblesse oblige is kind of the duty the nobles have to commoners in return for their status and privileges. Okay, so this is a duty-based thing where it's interesting. Yeah. Valpa says noblesse is medieval lords being generous to the folks because they're noble, stuff like that. Okay, that's interesting. So, but there is a relationship there where you're like a one versus many. So it's kind of like a doctor versus their patients, where they're the person in power at this kind of case. So they have to off-brand Aristotelian magnanimity. Okay, there we go. See, this is one of these things. People are not that clever. We are all pretty similar in some sense, but like the way we slice the pie up can be different, but we're still people. And so you put emphasis on different things. And I think it's kind of hilarious. In the US, we have this new Speaker of the House, and he's gotten himself into some wacky stuff in the past. But basically, they were doing a humor theory where you've got like different liquids in the body, and they were trying to treat people with like these old humor theories. But like this is the same thing. These like different virtues, they're all going to cover different human emotions more or less. Some more, some less. And it's like they're going to cover the different ways we're going to do it. So it's like the emphasis in the East is looking like they've emphasized certain things differently in the West. Of course, we can describe them as like chat has been doing. But it's just like it seems like this is how we've been doing things for a long time. It's like you've got different levels of these sort of, whatever you want to call them, virtues, humors, substances, concepts, whatever. But it's like, this is just how we go about doing stuff. And the idea that we are getting away from that, I find one of the conceits of modern thought, that we think we're way better than they were in the past. The stuff we're doing now, I feel like, is just going to be looked at as humor theory. We look at as humor theory now. And so it's like, you shouldn't crap on the humor theory, and you shouldn't crap on Bushido or any of these other old theories, because it was capturing something of the human experience. Okay. Yeah, so there's something of the interest in the group, such as a family, in contrast to Western individualism. Of course, we overdo that here in the U.S. with the individualism. Okay. In analyzing Shinmi through the lens of virtue ethics, we could find similarities between elements of the physician virtue and Shinmi. On the other hand, in the previous section, we described that elements of Shinmi potentially contrast or conflict with the traditional medical ideals in the West. However, the importance of familism and emotional involvement has recently been recognized or reassessed in Western cultures. The first element, familism, appears particularly desirable in cultures with a Confucian regard for the importance of family. However, many patients, even outside Japan, regard being treated like family by healthcare professionals as something that medical care should aspire to. Perhaps people believe that a doctor's family member receives better care than a doctor's non-family member. In the UK, the Friends and Family test is used to assess healthcare quality, asking people, including those who work in the National Health Service, whether they would be willing to recommend a healthcare provider to a family member or friend if they were in the same position. It suggests that the level of healthcare that would be sufficient to refer to one's loved ones may be considered the minimum required. So this is interesting. They're saying, would you refer your mom to this doctor? And if you would, that actually is sort of a proxy measure for this like family values thing here. The second element, effective closeness, has also been reevaluated. Although, as noted, analysis of doctors' empathy has previously suggested that doctors should avoid effective empathy, Michalik et al. Expressed concern that focusing too much on cognitive empathy to the exclusion of emotional empathy ultimately might have a negative impact on patient care. Unreal says, when I was living with a physician, I definitely got moved to the front line with her colleagues. What does that mean? Oh, you got moved to the front of the line with her colleagues. Yeah, you got bumped up. A little preferential treatment. Happens, of course. Yeah. Valpy says, the term noblesse oblige turns up super late 19th century, but probably referring back to medieval ideas. Yeah. Maybe it was sort of like an apologetics term that they were saying, oh, no, the lords had obligation to their peasants, when back in the day, they were just shitheads. Maybe, like, did the lords really actually have obligation, or is this whitewashing? Like our history washing of like their crappy behavior. That's interesting though. I mean, this is a thing. You see this also in, like, I've heard this about the Japanese and stuff. Like there was movies like, making the Japanese samurai look like great like leaders and lords and stuff, when chances are it was just the same bullshit, like rich people, abusing the workers underneath. It's like, well, why you valorize the samurai and the old attitudes? It's like, who knows? It's like apologetics for old bad behavior. Okay. Yeah, so even people are starting to question whether we should be completely detached. 19th century starts to get really nationalistic, so maybe that's a factor. Exactly, but cool swords. No, I mean, that's the thing. Were they really noble? Were they really following Bushido? Like, were they actually this way? Or were they, the same shitheads we all were, and they, paid lip service to Bushido, and now we look back on it like, oh, the good old times when people had virtue. It's like, no, shithead. People were people back then, too. But we need Shane to actually adjudicate this sort of problem, so I don't know. But I do know people. People will make up excuses. That I do know. Yeah. So this is the thing. Is it really, should we have no emotional engagement with your doctors? Is it better to go, to a computer, just like an ATM machine, stick your arm in, have it run tests on you, and then output a result. I don't know if that's good. Probably isn't. So I bet people are starting to realize that. Such an approach may lead to overemphasis on clinical knowledge, clinical detachment, and scientific rationality. Wong et al., in a study of exploration of oncologists' professional emotional experiences, found that some professionals reported engaging more emotionally with their patients to meet their affective needs and perceive it as an essential strength of being a doctor. In this research, doctors attempted to strike an appropriate balance between keeping themselves as objective and competent doctors and engaging more emotionally with their patients. From our analysis of Shinmi through the virtue ethics lens, we argue that Shinmi can potentially include desirable character traits if doctors properly pursue Shinmi. What should doctors look for to achieve the golden mean of the Shinmi in healthcare? Admiral says, in my own experience, there's a friendly but professional relationship character that works well. That's the thing, but where exactly? Where's the line and how to draw that? What were I was reading? I don't know if it was on Roulette or someplace else. I think it was Roulette, where we were talking about emergency dispatchers, and that they were using AI to. I think it was maybe one of those AI in Society papers where they were using AI to say, should an ambulance be sent out immediately, or what sort of like care needs to be sent out right now. And the AI would get the right answer faster and better than the AI dispatcher. So the artificial intelligence could hear whatever was going on in like the person's voice or whatever else, and would be more accurate in sending out the proper sort of like, do we need an ambulance right now, before the person could do it. So in some sense, you need both nowadays. You need like the technical, just like, black box solution saying, no, this person needs medical attention this minute, versus the person who understands the problem. That's the thing. People lie, though. They may say they need something. Like, there's all this discussion nowadays of like people saying, oh, I need this kind of like opiate because, they're addicted to opiates. And, it's like you have to have someone who knows that they're lying to you. If you just plug them into a system and they check off all the boxes because they know how to game the system, then believe me, the drug addicts will learn how to game the system, and then they will. But the A will never notice because it gives the right answer all the time, or the white answer. Yeah, and like as if the AI is like, giving the right answers. And I brought this up before. God forbid you're a black woman and you're trying to get the proper level of medical care. Like, that's the numbers. You're probably not going to get the same quality of medical care. And oh my God forbid you're getting your face run through facial recognition technology. It was trained on white people and just does not handle black faces very well and will just like spit out crappy results. And so it's like the white answer in some sense is not going to be very helpful for black people quite often. So it's like, yeah, we've got problems. But that's the thing. You having a good doctor that actually you can talk to then may cancel out some of these, rough edges that we have in care. Maybe not, I don't know, but like, this is the question. If they treat you better, maybe you'll talk to them more, they understand more of your concerns. That's the thing. Personally, I have a no whining policy. Like, no whining. Just don't do it. I was sick at one point, and my doctor was like, all the other patients, like, they complain about stuff. Like, you don't complain. He brought this up to me. And I was like, I have a no whining policy. He goes, what? I say, no whining. He goes, what do you mean no whining? I said, there's no fucking whining. I don't whine. And he goes, that's weird. I forgot about that. That was his reaction. He goes, that's weird. It's okay, but it's weird. At the time, I was more stoic. But I still don't like whining. I don't see what the point is. It is problematic. Oh, it could be problematic. I wouldn't tell them. It wasn't like I had a problem telling them what my symptoms were, but like it was like he was just like, "Why don't you complain?" I'm like, "What's the point in complaining?" You don't whine. Oh, I'm a curmudgeon. I'm a terrible curmudgeon. I think everything is terrible. I don't complain about it though. I mean, I could go on constantly if I was going to complain. Yeah. Because whining is part of language. Well, I use my language in other ways. But let's see. If you say the pain is 9 out of 10, but you aren't adequately performing the pain, you don't get taken seriously? I've got some fun stories about having to do that. Like, I've said other things. I said, look, I have 3 pain settings: normal pain, unnormal pain, and death. And any given point, that's normal pain. Unnormal pain means I have to go, like, you get medical attention. And death. I've been death is, like, as far as I'm concerned, I've gone into ERs and said, look, I've got pain, normal pain, and death. As far as you're concerned, I'm at 11 right now because I'm approaching death. So I was like, I've had to do that before. So I was like, yeah, they take you seriously when you say things like that, though. O'Neill says, just like they give me shots and I'm completely unaffected and don't flinch or react. 50 years, type 1 diabetic gets you used to needles. Yeah. Complaints have limited utility. Yeah. So it's like, this is the thing. But you still have to be able to talk to your doctors. Like, I'm not complaining as a way to communicate things. I don't whine. It's like, I don't complain about stuff. I will tell you what my symptoms are, but like, there's no point in being like, and it's really annoying. It's like, no shit. Of course it's really annoying. But like, yeah. So this is the thing. So, but again, the doctors need to know the information. If the doctors don't know the information, then they're going to be, deficient in like what their input is to give you the output. Same with computers. If you give the computer like limited information, garbage in, garbage out. That's how computers work. There is no getting around that. And so the idea that AI is going to overcome that, that's not true, and it will be gamed. Like it will be. So it's like there is like some space here, and that I think is the point of this paper, is that like what is a good area that we could work on in some sense in having a relationship in this sort of like in this space between the people and the doctors, patients and the doctors. Yeah, the golden mean of Shinmi in healthcare. Like who knows what that is, but we can have this discussion. So yeah. Forgot he called me weird after I said no complaining, no whining. Okay. The risks common to the 2 elements of Shinmi are loss of professional objectivity due to the blurring of professional boundaries with the patient and lack of equity as a public servant. Additionally, affective closeness can undermine the mental well-being of the doctor. Aris, there is something, of course, there's overlap between the cynics and the stoics. Like, the cynics, of course, they're like, well, from my perspective, I don't want to be a whiner as part of my character. As a stoic, you're just supposed to grin and bear it because you're stoic. I have a better reason. Like, I think it's like whining isn't a good trait for a person. Frankly, I don't want to hear whining. I don't like it. Like it just like, I'm like, what are you doing? Now, of course, the greasy wheel gets the squeaky wheel gets the grease. Like, if you want to actually get stuff done, sometimes you do have to complain over and over again. I'd rather that be strategic than just be a character trait, though. So it's like, there's definitely things to be said in this area. Okay. Firstly, to keep professional objectivity, as it has been suggested that self-reflection is necessary in terms of an awareness of the boundaries between doctor and patient for ethically sound clinical practice to take place. Yeah, sure. You have to have some objectivity. Wong and Frum suggest 2 reflective questions. Am I being professional? Am I acting professionally? Are essential questions to ask doctors themselves when performing emotional labor. These questions are also important to maintain professional justice and proper emotional distance with the patient. Frank says, but if you only do it when you strategically decide to, you are doing it too rarely. Society is balanced around you whining more often. And maybe that's why I'm fucking broke. Like, I should, society is not geared to me. I know this. Like, it never felt that it was. So, like, it's fair. It's like, yeah, society is geared to other people. That's okay. I don't give a shit. Like, I'm not going to change because whiners are doing better. It's like, that's fine. I'll find some other way. I don't want to be a whiny person, though. Like, I don't give a shit if, like, things sometimes go better for whiners. I feel bad for them. I think it's crappy that you have to go around whining all day. Like, I don't give a fuck. Aristotle says, I knew a guy who, whenever discussing problem, he'd explain, I have an idea, and we'd all look at him and he'd say, let's bitch and moan about it. That's funny, actually. But, like, was he doing it to, like, poke fun at the people who bitch and moan about it? Or did he really mean it as, like, a cathartic thing? Like, I don't know. But, like, yeah, it's like, what's he, like, what was his point, though? I was like, you want to bitch and moan about it? I was like, yeah, maybe you want to get it all out. Like, that isn't the worst thing, but, like, yeah. He was poking fun. It was funny. Yeah. Like, so like that's clever a little bit. It's like, why don't we whine about this more? Like, what does that do? Like, what's the payoff here? So, I mean, you could say this is consequential still. Like, what's the real payoff of being whiny? And like, there's not, but see, this is one of my problems with deontology. You're not going to be able to discuss this sort of problem in deontology. Where's there going to be a giant rule never to whine? Of course, maybe whining is there. It's like if everyone stopped whining, I don't know how the world would be. But like this is the sort of thing I think is better on virtue ethics and maybe on utilitarianism. Is like this everyday sort of thing. Like I have a policy, no whining. It's like it's just I've had it forever at this point. So it's like, how do you talk about this everyday stuff? Like, and this is one of my problems with deontology. It's like too heady. It's like these two big picture things. I mean, would this be super erogation not to whine? Like, really? Is it over and above to keep your mouth shut? Maybe. I don't know. All right, let's finish this up. Okay. Secondly, for balanced emotional involvement, sharing emotional experiences with colleagues, friends, and family may support doctors to reflect on their feelings. Cresidu et al. Also suggested that it is not enough to support the individual for the doctor to pursue the virtue appropriately, but it is also essential to create a supportive work environment that does not hinder the expression of the virtue. They mentioned that doctors could learn and acquire virtuous characters, but virtuous development is hindered if there is no place or opportunity to practice virtue. Yeah, and so this is one of the things Semiotics brought up. Can this scale? You are asking more of the doctors if you are asking them to also be emotionally involved with their patients. Can they just, take what the symptoms are and output the right treatment? Maybe. But if you're asking them to also look after the patient's mental well-being, then they're like psychologists, they're therapists and all this other stuff. So they need more support. And that's the thing. It's like you can get burnt out if you're overdoing it. So this is the question. Like maybe this is a higher level of care, but then the people providing the care need a higher level of support as well. Okay, conclusions. In this paper, we've introduced and analyzed a concept, Shinmi, that is used both by the public and professionals to capture an ideal of medical practice in Japan. Through our case examples and analysis, we have drawn out two distinctive elements of Shinmi: familism and emotional closeness. These elements are somewhat in contrast to and in perhaps conflict with Western medical ideals of impartiality and objectivity. Nevertheless, we have argued that if adopted to the right degree, Shinmi does appear to capture important and desirable character traits that are conducive to the goals of medicine. Elaborating and clarifying the concept of a virtue of Shinmi may be useful for medical education. Pellegrino refers to Aristotle. Quote, "We learn by practice, and that the best practice is to follow a model of the virtuous person. In medicine, this means we need virtuous physicians as teachers." End quote. Medical students in Japan should be taught as one of us was to treat their patients as if they were their own family. Learning Shinmi may be particularly important to meeting the special emotional needs of patients influenced by Confucian values who seek out health professionals in a familial relationship. Yeah, this is a thing. Like if you're talking to someone in this culture, they may be much more ready to talk to you if you understand their values. And so it's like, it may just be more like in that culture that this is important. But that doesn't mean it's not important in the West too. But like over there, they may not talk to you if they think like, you're don't understand them. Okay. However, professionals also need to appreciate the importance of balancing this against objectivity and the patient's own well-being, equity and the well-being of other patients, and prudence, taking care of their own physical and mental health. We have drawn on our personal and professional experience, but future empirical work would be valuable to explore how Shinmi is currently conceptualized and implemented in Japan. It would be interesting and valuable to investigate what specific attitudes make patients in Japan or elsewhere feel cared for like family. It would be illuminating to see whether there are parallel virtues in other countries influenced by Confucianism. We have suggested that this concept may have wider relevance. However, there is a need for further analysis to explore whether and how the concept of Shinmi could contribute to improving the patient-physician relationship in the West. And says a lot of indigenous communities in South America don't like the white researchers because they know they are being used for the researchers' benefit and they are not understood. Yes. So like again, like this is the thing. We in the West, like in the United States, minorities have been treated like crap, and I guess indigenous communities in South America they feel like they're being used, and they are being used for other people's academic or whatever advancement. And so it's like, they may not be willing or to tell all the things that they know, or like let people into like their society in the right way. So the things that are being told are going to be skewed. And so that's the thing. Okay, so let's give it a little review. Everyone, well, on the Twitch side, if you're over on YouTube, we got a message here. Sorry if I missed it. Oh no, someone just being jack, fucking whatever. Anyway, if you're in chat or in the Twitch chat, please grab one of the emotes. We have this is the emote review. If it was a fun article and with fun ideas, brain dance. If it made big claims that shriveled up, then the grapes. Nasal gazing, was this only for academics, or was this for a wider public? Or Ouroboros, did this deal with deep ancient ideas? Scream for the existential artistic drama, turd for all style no substance, and knife for slicing and dicing arguments. Unreal says that definitely happens with native communities and linguistics research too. So this is the thing. I think this is a nice paper because it discusses something that is at the edge of like Western science. Western science is looking for the objectivity, but this is a problem. You get the objectivity you're using is not going to, engage with people who are not trying to be objective here. So Unreal Brian says, yeah, nay, but it was a fun paper. So Unreal Brian did not like this, but did think it was kind of fun. Thank you for your review. What am I going to say about this? I don't know. I mean, this is not attempting to do any great thing. This was basically describing one thing and saying what it was. Nay, you feel mean because it wasn't bad. You can be a humbug. That's fine. This is philosophy. You're entitled to your old grumpy man opinions. You're with me? Yeah. So you can give it a yay and a nay. So that would give it one of each. So that's, I don't have a very meh version here, but I feel like chat hates these papers ever. Usually because this is like putting something out there, but it's not particularly deep, Yeah, get off my name. Nagyay. It's the yay is global. It's vote yay. So you have to put vote yay. What is it? It's Twitch global, and so if you want to do it, you can. But yeah, thank you, Frank. Are yay and nay counted up that way? Yeah, everything's counted. So it's how many of each individual emote you use. So yeah, it's vote yay. Thank you, Unreal. If you want to do that without the spaces, of course. So yeah, Frank thinks so. And if you actually do something like, I'm gonna say vote yay. I think, vote yay, and then if you put a comment here, it actually saves the comment next to your thing. I don't know what I'm gonna do with the comments, but yeah. But I mean, you have an overall count of the two which relate to one another. Yeah, I'm gonna put that in. So like that's kind of the goal here, is to have a both a like just the reviews people have, but then also have counting up the emotes that get used. So if you do like a bunch of vote nays, that will matter more than just one vote nay. Like in some sense, like I'm gonna have ways to search, like okay, things that were voted nay on, and then things that were voted yay on, but then you're gonna be sorting them by counts. So that's the thing. Yeah, one of each is probably right, but I shouldn't have done both in the same comment. It doesn't matter if it's in the same comment. All of that will get the comment actually gets aggregated. So yeah. But yeah, I don't know if this is any big ideas or anything on this paper. So in some sense, it's like, it's just not that, I don't know if like, it's like an interesting idea. They put together a little paper. This is just in like the, whatever corner. It says like, this is just their discussion corner. So it's like perspective corner here. To balance it out, you'll give it a second one of those. That's fine. So it's like, this is the thing. No rating system is perfect. I took a long time to come up with this one. I thank you all for rating, but, yeah, it's like, I don't know if I have anything else to say. It is an interesting idea. I don't think this was like a whole lot of fun ideas in this, but it's like one interesting idea that they're pointing out. And it would have been nice if they like, had some compare and contrast with like other of these ideas. Like I said, bedside manner is a phrase. I don't know if maybe these people know it. Like, where is this? So I take Ozeki-Hayashi is Japanese, I assume. And And okay, Dominic J.C. Wilson is out of philosophy in Oxford. So so they're for Center for Practical Ethics, Philosophy, Faculty of Philosophy, University of Oxford. Doesn't mean they're, British, but like, maybe they're German or something. Who knows? But that's the thing. So it's like, but like, this is the question. What is the correct bedside manner? It's like, this is a thing. Unreal says medical ethics is big shizzle right now, and this does bring a little something new to the table. That's the thing. This isn't really doing anything much, but it's like doing something. So yeah, I don't know. So like, I don't have a problem with this. Like, we have the grapes or the golden turd. For golden turd is for like, fancy shit that doesn't really do anything. The grapes is for like, they make big claims and it fails. This didn't make any big claims. It made a small claim and it backed it up. And that's fine. So it's like, it's okay. But yeah, so thank you all for rating. I'll leave it up for another minute if anyone else wants to jump in or, try to even out their votes.